Are there people at St. Paul's? Can I see you there? I think so. Yeah, great.
Yep.
Okay, good. Hi, David. All right, so it's 7:33. So because it's 7:33, we will start. So welcome to Province Ride Round for January the 24th. So it's a great pleasure to introduce Dr. Neesh Pannu. She's a professor of medicine at the University of Alberta in Edmonton and has trained both in Alberta at U of C and U of A, but also at Stanford and at Harvard, and obtained, she's double boarded in both nephrology and ICU. And her interest all along has been in acute kidney injury, as well as understanding the impact of acute kidney injury and chronic kidney diseases, amongst other things. And she works collaboratively both nationally and internationally. And it gives us great pleasure for her to have her come and talk to us today about things that are new and different and how we should be thinking about acute kidney injury. So welcome.
Thanks, Dira, and thank you very much for inviting me here to talk about this. So I realize it's a rather vague topic description, but I thought I would just cover a few things while I'm here. So we've been, I think, a lot of people, a lot of nephrologists will say, we don't really take care of AKI. It's an ICU thing. People don't necessarily consult us about it. Why do we care about patients who have acute kidney injury? There's nothing we can do about it anyways. And I'm here to convince you that maybe that's not true. I want to, I'll talk a little bit about AKI as a public health issue, about how to, use all of the current literature about acute kidney injury in a clinical context. I'll give you a bit of information about biomarkers and how they may be applicable in the near future. I'll talk a little bit about electronic health records. We also just implemented EPIC in Alberta, so we're certainly share your pain when it comes to using electronic health records, but this may also be an opportunity. A lot of the really key work with predictive analytics has been done in acute kidney injury, so we are actually leaders in this field. I'll finally talk a little bit about outcomes after acute kidney injury, and specifically several initiatives that we have undertaken in Alberta on a province-wide scale. So Matt James from the University of Calgary and I have done quite a bit of work with our strategic clinical network in terms of care pathways, both for identification and management of acute kidney injury in hospital, as well as management of acute kidney injury after hospital discharge. So just things that we've been doing and that might give you food for thought and maybe change your mind about acute kidney injury. So just a couple of things to put it in context. Many of you may have seen these slides. So there were a couple of papers that came out in the early 2000s that were replicated again in the sort of around 2012, 2013 that talked about the rising incidence of acute kidney injury and acute dialysis. And this is all American data. Basically, that was identifying acute kidney injury either through administrative codes or identifying it as dialysis. But the short of it is that there's been about a 10% increase in AKI year over year. And that's been reported since about 1996, and this continues to be the case. And there is equivalent Canadian data. So this is work done by Emmett Garg and Mike Walsh and Ron Wald, and this was published again. This is now almost 8 years old. And similar data, just local data that we've looked at in the province of Alberta shows similar trends. So certainly we're seeing more patients with acute kidney injury, and we're seeing and requiring dialysis. And there's probably lots of different reasons for that. The people that we're admitting are sicker. We're doing more complex procedures on people with more morbidity. In terms of the public health implications of this, I think, we know that it's associated with increased mortality, increased hospital length of stay, but more interestingly, as nephrologists, I think, we're also seeing these people develop chronic kidney disease and progress to end-stage renal disease. So whether there are patients to start with, requiring dialysis or not, they end up being our patients. And so all of these translate to increased healthcare costs, and that is a public health issue. So, it is not a small problem. This is data from Alberta, so this is work that Scott Clarenbach and I did using a provincial cohort of patients, and we're just trying to cost out. This is in-hospital acute kidney injury. So if you just kind of look at the top of that slide, patients with no acute kidney injury, so these were patients hospitalized between 2002 to 2009. It's kind of older data now. But again, we've just actually repeated these analyses. And we looked at what the cost of stage one, so this is a 25 change in serum creatinine. Well, we can talk about the clinical relevance of that change, and I will talk about that, but the short of it is that any mild acute kidney injury is associated with an incremental cost of about 25% more than somebody who doesn't have it, and then when you go to requiring dialysis, you can see that cost triples. So it is a significant driver of healthcare costs. It's a significant, particularly in the surgical population, it's probably the most costly post-surgical complication. So it's not, and it's associated, as you can see, with significant short-term and long-term mortality. So the other thing about acute kidney injury to think about is that 20 years ago, 25 years ago, when people required dialysis, they would die. So the mortality associated with acute kidney injury, probably due to better critical care, maybe better dialysis care provided by us, has resulted in the fact that these people are now, people with acute kidney injury are actually living to make it to hospital discharge and after. So again, we're accumulating this significant population of people who've survived their acute kidney injury with multiple comorbidities often that we now have to care for. So, I mean, in reality, I think most patients who survive acute kidney injury will recover kidney function, but they are also, in addition to chronic kidney disease, there are other repercussions of acute kidney injury, and I will talk a little bit about this and why we as nephrologists have a role in managing some of these other issues. So this is just unpublished data. So this is one of my former residents, Sandeep Brar, and I were kind of looking at who takes care of patients with acute kidney injury in hospital. And so we assembled a cohort of patients in the province between 2009 and 2012 who had at least stage 2 AKI, so at least a doubling of serum creatinine. And the only thing I want to point out on this slide is that only about 30% of those people saw a nephrologist during their hospitalization. So most of the time we aren't called. We are called about acute kidney injury, but 2/3 of the time we're not. So, and in fact, if you look at within 1 year after discharge, only about 1/3 of those patients will have ever seen a nephrologist. So not only are they not seen in hospital, but they're not seen after discharge. And what's specifically interesting about this is that this particular cohort all had chronic kidney disease or a sustained serum creatinine less than 60, or sorry, a eGFR less than 60 after hospital discharge. So they had known CKD after an AKI episode, and only 1/3 of them saw a nephrologist. So why is that important? Well, it has implications for obviously appropriate management of chronic kidney disease. So, not only, while these people often will get screened and will get serum creatinines done after hospital discharge and urinalyses, they're often not restarted on their ACE inhibitors or their ARBs, they're not started on their statins, they don't receive all of those nephroprotective and cardioprotective drugs that have been shown to be benefit in chronic kidney disease. So our role here may actually just be an appropriate management of chronic kidney disease after an AKI episode. So, in terms of sort of AKI epidemiology, we know that there are more patients developing AKI, more people are surviving AKI after hospital discharge. We know that those patients are going to go on to develop chronic kidney disease and end-stage renal disease. So, there's been a lot of discussion, and, last year I attended a KDIGO meeting to discuss this issue about how are we diagnosing AKI? As all of you know, there have been a number of definitions that have been put forward in the last 15 years. So initially it was the Rifle criteria. Glenn Shortow had written a paper in the early 2000s looking at and demonstrating that there was a significant mortality associated with the 25% increase in serum creatinine. And so we started, whereas AKI used to be diagnosed at the time that somebody required dialysis, there was this recognition that perhaps lesser degrees of kidney injury were important, and the definitions have kind of evolved over the years. And while they have been sort of interesting from an epidemiological point of view, and certainly correlate with poor short-term and long-term outcomes, I think a lot of people legitimately question what the clinical application of these small changes in serum creatinine are. And one of the criticisms which I think does need to be addressed is the fact that these are assuming that AKI is the same regardless of etiology, which clearly it isn't. So, the prognosis obviously significantly changes depending on what the cause of your AKI is, whether you have comorbidity, and what the severity, the duration of the AKI is. All of these things are important and are not incorporated in any kind of current definitions. So, most of us don't want to be called for a 25% change in serum creatinine because there's not really much that we would do necessarily. So understanding and narrowing the AKI definition, I think, is important so that we can potentially consider specific interventions depending on the etiology. The other issue is that many of the current definitions, the current KDIGO definition has restrictions in terms of timing and has urine output as a definition, and we don't typically measure those things. So outside of an intensive care unit, can we accurately measure urine output? I would say no. If we're sort of beholden to a 48-hour time frame for a change in serum creatinine or a 7-day time frame, how does that apply to our outpatient population? How do we, when somebody comes in with a serum creatinine that's high, what does that mean? So, all of these things are problematic with our current definitions. And we also know that creatinine is a terrible marker of kidney function anyways. So it's late in terms of its change in the serum, and there are probably other better markers, or serum creatinine could be potentially used with a combination of other markers. So this is a paper that our group, Matt James from Calgary, was the first author in this paper. It came out last year, and it was really to talk about maybe what the real scope of AKI is. So if we take ourselves away from that 25% change in serum creatinine definition, and we look at people who actually have changes in serum creatinine that we would consider acute. So in this case, we were exploring the idea of acute kidney disease. So people who had what we thought was AKI, so some change in serum creatinine over a short time frame, but wasn't beholden to that 7-day or 48-hour time frame. And what we found was that, in fact, twice as many people had AKI as has been previously reported, because lots of people have AKI that doesn't fit into current KDIGO definitions. And not only that, but those people had fairly poor outcomes as well. So if your creatinine went up, in 8 days instead of 7, for example, you would not necessarily meet the definition of acute kidney injury. But clearly those people have AKI. So when we explored to see what were the outcomes associated with people who had this so-called acute kidney disease, so a change in serum creatinine that occurs over a shorter time frame, like 90 days, those people also had a poor outcome. So the actual population of people with acute changes in kidney function is obviously much bigger than what we currently define using AKI criteria. And so this has kind of opened up a broader discussion about the current definitions of acute kidney injury, and they will likely, I would imagine, be revisited in the next couple of years. So I'm just going to shift to the idea of biomarkers. I think lots of people have been interested in biomarkers. There's been a lot published about biomarkers, and the thought is that biomarkers might be able to actually narrow that AKI definition beyond just a change in serum creatinine. So as you can see, there's been an explosion of biomarker research in the last decade. And despite that, there are relatively few biomarkers that are in clinical practice. In fact, there's only one in the United States, which is called NephroCheck, and I'll talk about that in a second. That's been approved by the FDA, but many of you have heard about NGAL and IL-18 and kidney injury molecule 1 and fatty acid binding protein. And all of these are urine biomarkers. Some of them are serum biomarkers as well that seem to have some ability to predict acute kidney injury a little bit earlier than serum creatinine does. So if we just assume that serum creatinine goes up about 48 hours after a renal insult happens, you can see that most of these biomarkers will be elevated probably at an earlier time frame. The duration over which they're elevated is variable from biomarker to biomarker. And there's been a proposal that perhaps maybe a combination of biomarkers, maybe IL-18, NGAL, and maybe KIM-1, for example, could be used in combination to diagnose and for diagnostic and prognostic reasons. That being said, In terms of the role of biomarkers in the identification and management of acute kidney injury, there's a couple of places where they may be of benefit. So early recognition might be one area. So identification of so-called subclinical acute kidney injury. They could potentially give some information about the underlying etiology, distinguishing ATN from other causes of acute kidney injury, for example. Some of them may have some prognostic value in terms of determining which patients might develop severe acute kidney injury versus others. So those are all potential uses, and there's probably 4 clinical scenarios that we can currently identify where biomarkers may be of help. So, and one would be, in an acutely hospitalized patient, distinguishing pre-renal AKI versus ATN, which might be one scenario where we could potentially use biomarkers. Another one is cirrhosis, and there's been some really interesting literature about the use of biomarkers in cirrhosis. The third scenario would be cardiorenal syndrome. And again, there's interesting data now in patients with acute decompensated heart failure and the significance of elevations in serum creatinine in that population. And using a biomarker might be able to distinguish between, may be able to guide therapy. And the fourth scenario where there might be a benefit would be in the allocation of kidneys from deceased donors. So I'll just spend just a minute to talk about those. So in terms of, using biomarkers in a typical sort of nephrology consult sort of situation, there would be value to being able to accurately predict whether a patient has pre-renal, so-called pre-renal AKI versus other forms. And we all have our ways of making that distinction, whether it's fractional excretion of sodium, whether it's urinalysis, changes in urinalysis, or urine concentration. But often, as we all know in clinical practice, it's a retrospective diagnosis. You give somebody fluid, if they get better, it was pre-renal, if they don't get better, it was ATN. That issue, that may be okay for some people, but there is some, concern about giving fluid to a patient who may not need it, particularly if they've got underlying problems with heart failure or chronic kidney disease. So one potential role for biomarkers, and there is a significant body of evidence now to support this, would be the idea that you could use potentially a combination of panel of biomarkers, IL-18, NGAL, liver fatty acid binding protein, or KIM1, and all of those are elevated in acute tubular injury, or ATN, versus pre-renal. So that might be one potential scenario where we could think about using biomarkers in the future, instead of doing our usual fluid challenge and then making a decision retrospectively. Cirrhosis is another interesting one. So, it's difficult to assess kidney function in patients with cirrhosis. Serum creatinine is a very poor marker of GFR in these patients. They can have very low GFRs with serum creatinines that are in a normal range. And the thing particularly about acute kidney injury in these patients is that there are significantly different management decisions you would make based on the etiology of the AKI in that patient. So obviously, pre-renal AKI is pretty easy to manage. Hepatorenal syndrome versus ATM are different. So hepatorenal syndrome is associated with a very high mortality, but a very low risk of CKD. So the treatment for that is transplant. ATN, on the other hand, is associated with a relatively low short-term mortality, but poor outcomes after liver transplant. So these have implications for both nephrologists taking care of these patients, potentially for immune suppression after a liver transplant, whether you would want to choose a CNI sparing regimen, for example. So in that scenario, biomarkers may be of benefit. So certainly, again, NGAL, liver fatty acid binding protein, IL-18, tend to be elevated in people who have acute tubular injury. They tend to not be elevated in people who have hepatorenal syndrome. So again, biomarkers could have a very sort of a significant role in the treatment of acute kidney injury in that scenario, and potentially for nephrologists with regards to allocation of, I don't know what the current practice is in Canada, but certainly in the US, many of these patients with prolonged acute kidney injury will receive concurrent kidney transplants as well. So, these biomarkers may be of benefit in terms of determining renal prognosis after a liver transplant as well. Heart failure is another interesting scenario. Often we are consulted. I don't know what it's like here, but certainly at home we are frequently consulted by the cardiac hospital in terms of managing their diuretics. So this would be a situation where, and the balance here is that there is recent literature to suggest that short-term increases in serum creatinine during diuresis might actually result, maybe associated with a better prognosis in patients with heart failure. So then the question is, when a creatinine is elevated in somebody who's being diuresed, do you keep going or do you stop? So often we stop. So, and this would be another scenario where a marker of injury might help you guide that decision. So NGAL, NAG, KIM1, urine albumin excretion have all been shown to be elevated in patients with ATI versus a pre-renal cause or a hemodynamic cause of a change in serum creatinine. So again, this is another specific clinical scenario where biomarkers may be of use in the near future. The other interesting sort of prognostic marker here is hematocrit. So people who bump their hematocrit during a diuresis, that is considered a good prognostic marker. Again, suggesting that the diuresis is just improving cardiac hemodynamics and you just have to wait it out and not worry so much about the serum creatinine. Finally, is there potentially a role for biomarkers in deceased donor evaluation? So, certainly many patients, like donors who have AKI, are certainly, those kidneys are more likely to be discarded than donors that don't have acute kidney injury. And could biomarkers potentially give you some information about the function of those kidneys and if they would be viable for use in a transplant? And there's been some interesting work done in this area as well. So there is a marker YKL40, which is a marker of repair, in fact. And and several studies have shown that increased YKL 40 is associated with better outcomes in donors with an elevated terminal serum creatinine. So again, they can kind of predict people who will have delayed graft function versus no delayed graft function. And then in patients or in kidneys that do have delayed graft function, the use of biomarkers will give some prognostic information about GFR at 6 months as well. So, this also could be potentially useful in terms of determining your immune suppression regimen after a transplant in these patients. So, again, there are potential uses for these things, and I think they will continue to evolve as we have a better understanding of biomarkers and they become more publicly available. Now, as I said before, the only biomarker that's currently available in North America for clinical use is TIMP2, and this is a relatively new kid on the block. And so it's marketed as NephroCheck in the United States, and in fact is being now used in many ICUs across the US as a biomarker for acute kidney injury. It's a cell cycle arrest protein, and it's usually expressed during periods of cellular stress. There have been a number of large observational studies that have compared this TIMP2 to the traditional AKI biomarkers, NGAL, all of the ones that I mentioned before. And TIMP2 performed the best out of all in terms of its ability to predict acute kidney injury, and specifically severe acute kidney injury. So the stuff that we care about, AKI 2 and 3, so doubling or worse cases of acute kidney injury. But perhaps the best use for it is the fact that it has a fairly significant negative predictive value. So, and the particular scenarios where it's been best studied have been in cardiac surgery, for example, and in sepsis. And so in patients who have a negative NephroCheck, they have a very, very low risk of developing acute kidney injury. So for example, it's now being used in cardiac ICUs to determine discharge planning. So rapid extubation protocols, getting them out of the intensive care unit faster. So if you have a negative NephroCheck after cardiac surgery, the likelihood of you developing acute kidney injury is extremely low. So those people can be protocolized to rapid discharge. So its value may be there. So there's been one small randomized trial that was done in Germany in a single center where they actually used NephroCheck to randomize patients after cardiac surgery to nephroprotective versus non-nephroprotective strategies. The nephroprotective strategies were essentially the KDIGO recommendations. So avoid nephrotoxins, all of the, like obvious things that we would do anyways. Make sure volume status is optimized. All of those kinds of sort of general sort of conservative maneuvers that we provide to patients with acute kidney injury. And they were able to demonstrate in a small cohort of patients that using NephroCheck and using and randomizing high-risk patients to a nephro protective protocol resulted in a reduction in acute kidney injury in those patients. And that study is now that was a pilot trial, and now there's a multi-center study that's ongoing that's looking at using NephroCheck for that purpose. So it's certainly interesting. No one's looked at it in kidney transplant populations or other populations. So I think there's going to be probably a large body of work coming out evaluating the utility of this outside of the intensive care unit. So in fact, maybe a more rational approach to the clinical diagnosis of AKI will not just be changes in serum creatinine, but also with some incorporation of biomarkers, whatever that biomarker is, whether it's NephroCheck or something else. And with the idea that if you're biomarker positive, then you're either at high risk of AKI or you have AKI. And if you're biomarker negative, maybe we're looking at hemodynamic things that are causing your change in serum creatinine. And maybe that's a more rational approach to diagnosing AKI versus just looking at a change in serum creatinine, which is what the current definitions rely on. Okay, so what about using data as an AKI biomarker? So I was just going to say a few things about this because there's been really some interesting work done using electronic health records, and particularly AI. So the nice thing about electronic health records is that you don't have to is that data is free, and you can incorporate all the data that's in an EHR and put it into a predictive model. So AKI has really been one of the it has been sort of the condition that people have been working on with regards to predictive analytics because it's easy to diagnose as a change in serum creatinine, and you have so much clinical data on these patients. So in fact, many of the publications on using AI and predictive analytics have been in the area of acute kidney injury. So how could electronic health records improve the care of these patients? There's probably lots of different ways that you could think about how you might be able to improve the care for any individual patient. Predicting who's going to have AKI is important. You could potentially, if you knew who's going to have AKI, you can anticipate that and then already look at things like removing potential nephrotoxins, stopping NSAIDs, taking away medications that may exacerbate changes in kidney function. From a health system point of view, you can certainly track patients who have AKI. You can make sure that they're followed after hospital discharge. So there's lots of ways that electronic health records could potentially be leveraged to improve the care for patients with acute kidney injury. So there have been a number of studies, many of them from the UK, that have looked at e-alerting. So essentially alerting physicians or alerting care teams, alerting care providers when patients have acute kidney injury. And the initial studies were actually negative. So the first trial that looked at this was published in, I think it was in The Lancet, by Perry Wilson and the Yale group maybe 10 years ago. And what they actually found was that alerting physicians to patients who had acute kidney injury didn't actually help. It didn't improve outcomes. In fact, in some cases, particularly the surgical patients, it actually resulted in worse outcomes, probably because those people were getting fluid and they probably didn't need it. So, it's sort of over time, there have been a number of studies now that have looked at pairing e-alerting with interventions. So specifically, not only just telling care providers or care teams that a patient has acute kidney injury, but also providing education as well as care bundles. So optimizing volume status, maybe stopping diuretics or starting diuretics if appropriate, stopping NSAIDs, renally adjusting medication doses, rechecking serum creatinines, again, those types of interventions. So it's more quality improvement kind of work. And certainly e-alerting in association with quality improvement measures has shown an improvement in AKI outcomes. So this is a paper that was published in JASN in 2018, and they found that using a clinical decision support system actually did show a small reduction in mortality. Nicholas Selby and this group out of the UK actually didn't show a change in mortality, but did show a reduction in hospital length of stay and improved care delivery for patients with acute kidney injury. So, I think there's simple things that we can do to probably improve the quality of care for the patients that have this and potentially move the needle when it comes to mortality as well. So predictive analytics is kind of, there's been a lot of talk about the use of AI in medicine and particularly predictive analytics. And the idea is obviously to try and diagnose AKI before it even happens. So what is that constellation of clinical things that happens that can predict somebody who can develop acute kidney injury? And there was a really interesting paper that was published in Nature last year. So this made a lot of headlines. And essentially they used all of the VA data and all the VA inpatient data. And essentially, we're able to develop, using deep learning algorithms, a predictive model that could predict AKI 48 hours before it happened. So pretty good, actually. And this is just they had over 600 variables, and some of them are obvious, some of them are not obvious, but it was just trends in blood pressures, oxygen saturations, all that stuff that all the subtle things that we as clinicians can look at to say a patient's getting worse. But they were able to develop a predictive model that was actually pretty good in predicting acute kidney injury. And so there were 2 false positives for every AKI that predicted, but even the false positives were actually patients who it was actually predicting AKI earlier than 48 hours, or it was just catching AKI that was resolving. So in fact, it was actually a fairly accurate way to predict acute kidney injury. It doesn't use any, obviously development of predictive analytics isn't free, but it's not using a biomarker. It's just using clinically available data within an electronic health record. And I think we're going to see more and more of this. There have been a number of models now that have been put forward using a variety of electronic health record systems. Some of them have been in Epic, some of them have been, this one I don't think was an Epic. But this is certainly, I think, the way of the future, and I suspect that these will improve over time. So even though we all hate our electronic health records, they may be of use potentially in the future. So why should we care as nephrologists about all of this? Because these are our current and future patients. So as I said before, not only do these people have, with AKI have chronic kidney disease, but they also have a significant increased risk of stroke, myocardial infarction, heart failure, hypertension. So it is a marker for cardiovascular risk. So again, whether it causes the cardiovascular risk, and one could say maybe dysregulation in salt and water and volume changes and things like that might explain some of this associated increased risk, or whether AKI is just almost a biomarker of poor protoplasm, and these people are at higher cardiovascular risk. I think it's probably irrelevant. It doesn't really matter. The point is that somebody who has it is gonna go on to develop some of these other cardiovascular complications. And so this might be an opportunity for us to intervene in terms of cardiovascular risk reduction. So I'm just gonna kind of skip to this just to say that, so we know that, so this is USRDS data, and essentially about 20%, 20 to 30% of people after any kind of an AKI episode will have CKD after 1 year. So that's not a trivial number when you think about the number of cases of acute kidney injury. So if we're assuming that 15 to 20% of people have acute kidney injury during a hospitalization, and a third of them have sustained decrease in GFR after a year, that's not a trivial number. So these people, and as time goes on, many of these people will have progressive CKD and come to our attention. So is there an association between, does AKI actually cause CKD, or are we just looking at the same patient and they either get AKI or CKD, or AKI is just a marker for people developing CKD later? There is maybe an argument for causality. There has been some interesting data to support this. So this is a study that was done using VA data published by Meng Chawla in 2011. And really what he shows here is that the more severe your acute kidney injury is, the more likely that you will, the more severe the decrement in your kidney function after the AKI resolves. So your baseline eGFR or your serum creatinine after resolution of the AKI is going to be much lower as the severity of the AKI increases. We also know that multiple episodes of AKI predict CKD. So the more episodes of AKI you have, the more likely that you'll develop chronic kidney disease. Maybe the most interesting data is actually, this is BC data, so this is pediatric data from here. And what was reported here was the outcomes of children who developed acute kidney injury after 3 years. And what they found was that a significant number of them had, not only did they develop chronic kidney disease, but a significant number of them had hypertension and microalbuminuria. So again, and these were kids that were previously healthy. So these are not kids with multiple comorbidities as we often see in the adult population. So this would suggest that the AKI is maybe doing something to these patients. So, you know, there's clearly an association between AKI and cardiovascular risk. You know, often we see AKI in people who already have underlying cardiac pathology, whether it's after contrast, like for cardiac catheterization, after cardiac surgery, in the ICU in people who have multiple comorbidities. So, you know, we know that in those patients that they are at high risk for cardiovascular events after an acute kidney injury episode. What about in non-cardiac patients? Does the same thing hold true? And the answer is yes, it does. So while it's certainly been shown in cardiac patients, this is a paper that was published in the Annals of Surgery in 2016. This is data out of Florida. And what they actually show is that patients with acute kidney injury really had outcomes equivalent to patients with chronic kidney disease with regards to cardiovascular mortality. So we don't really think of it the same way. We know that patients with CKD have high cardiovascular mortality, but in fact, for these are patients who had non-cardiac surgery and had acute kidney injury episodes, and they had the same cardiovascular mortality as people with CKD. So we may not necessarily think of it that way, and if you actually look at it in terms of hazard ratios, you can see patients with acute kidney injury alone had a hazard ratio of around 2. Patients with chronic kidney disease without acute kidney injury also had a hazard ratio of 2. So, you know, we clearly identify one group as being at high risk, but we are probably neglecting this other group. And I think that's what our role is as nephrologists, is to make sure that these people are cared for in the same way that we care for our CKD people. In addition to which, I only wanted to point this out in this particular paper, there is a care gap. Very few of these patients are on a statin, are on an ACE inhibitor, or receive one after a hospital discharge. And again, this is Alberta data, and we looked at this, you know, in a number of ways. But again, you know, as you can see, after an AKI episode, in patients who had documented CKD after an AKI episode, only about 20% of them were on a statin. And a small group of them were also, only a small group of them were also on an ACE inhibitor. So, you know, I think this is an opportunity for where we can improve the care of these patients, because often these things are stopped when they're in hospital and they're never restarted, particularly if they never see a nephrologist, and they may never ever be restarted. So there are 2 initiatives that we've sort of undertaken in Alberta. One is called Support AKI, so strategies to improve the identification and management of acute kidney injury in hospitals across the province. And the second one is After AKI, which is a randomized trial where we are randomizing patients to nephrologist care or risk stratification nephrologist care after AKI versus usual care. So, and I'll just tell you a little bit about these studies, and then we can chat a bit further. So in terms of the first Support AKI project, so Matt and I have been working on this for probably 5 years. And it was a multi-step process. So we've been doing this in collaboration with our strategic clinical network. So for those of you that aren't familiar with this, these are sort of networks that were created by Alberta Health Services about 10 years ago. Kidney got one about 5 years ago. And these are collaboratives that essentially involve clinicians, patients, operations, so people, you know, providing care across the province, so the decision makers, as well as researchers, clinicians and researchers. And so essentially what we do is we work together, we identify high priorities for kidney care in the province, and we develop research initiatives or quality improvement initiatives to address them. So, and AKI was identified as one of these things, and so this is the approach that we took in Alberta to manage this particular issue. So the first thing we did was have, we had a sort of a multidisciplinary stakeholder meeting and got everybody's input into, do we agree that AKI is a problem? Where, if it is a problem, what is the best way that we can address it? So this is just, I wanted to just put this up to give you an idea of what our strategic clinical network is doing. So in addition to being a nephrologist and a researcher in AKI, I'm also scientific director for the Kidney Health SDN, and myself and Scott Clarenbach share this role. And essentially what we do is we identify essentially research priorities for the province in terms of patient sort of outcome-related research. And so this is our essentially our priority. These are our top 3 priorities in terms of improving the care for patients, and we have research or quality improvement projects in all of these areas. So certainly the AKI stuff met. Our first criteria was that it was of high priority for the province. So, and the initiative was really to recognize AKI, so develop strategies where people could find, recognize AKI. We had seen that particularly in surgical patients, nephrology is rarely ever consulted. They manage their own AKI and they often don't recognize it. So we were able to prove that AKI, we used our provincial data to show that about, that a large proportion of these patients develop AKI, nephrology is never consulted, and they're often diagnosed late and not probably appropriately managed in terms of avoidance of nephrotoxins, all of those things. So really our strategy was to develop strategies to recognize it, to respond to it early with specific interventions, so specific clinical guidance with regards to volume management, avoidance of nephrotoxins, pharmacy consults to make sure that all the drugs are appropriately dosed, and appropriate instructions for appropriate referral to nephrology. So, and this was done a couple of ways. So we actually leveraged, we didn't have an electronic health record at this time, but we do have a provincial lab data repository. And we were able to, and it was the SPORE platform actually in Alberta, and we actually had them develop algorithms that would allow us to identify AKI real time in all the hospitals in the province. And so they were able to develop these dashboards that were accessible to nursing staff and clinical staff in all of the hospital units, where they could log in every day and see who on their ward had acute kidney injury. So that really helped improve the identification of AKI, because often we had already determined that, particularly in surgical patients, they come, surgeons round at like 6 o'clock in the morning and they don't come back until 6 o'clock at night. If they come back, it's usually the house staff that come back and round on those patients, and then they'll respond to a lab. But 12 hours have already passed by the time they respond to that lab. And then we might get called as nephrologists maybe the next day, potentially. So this way, that alert process is happening early, and it's actually not being identified by the house staff. It's being identified by the nurses. So the unit clerks and the nurses flag who has AKI, and then they would then activate an order set. They would stick an order set, paper order sets in Edmonton, and in Calgary, this was all done through their electronic health record. But in Edmonton, we had paper order sets that were just slapped on the chart of that patient. And house staff would be notified saying, your patient has AKI, we've put an order set at the front of the chart. And we developed specific guidance with regards to volume management and all of the, it was essentially pre-printed order sets on how to manage AKI, including doing follow-up serum creatinines, which often weren't getting done. So we are, the third component of that intervention was we actually did specific education sessions with all of the nursing, mostly focusing on the allied health. So nursing staff, unit managers, as well as house staff. So Matt and I both did educational symposiums at Edmonton and Calgary for all the surgical house staff, because we focused this intervention initially on surgical patients, given their high rates of AKI and their relatively low requests for nephrology consults. So we combined an education strategy with it. So in order to make sure that these interventions work, we actually included process and outcome measures in our provincial dashboard metrics. So as from the Kidney Health SCN, so our part of supporting this project was to develop these KPIs and to monitor them. So all of this stuff will be reported back to all of those units, as well as to the leadership in the Kidney Health Strategic Clinical Network, in order to make sure that this intervention is sustained and that it's actually showing improvement. So in terms of the results, we are actually just getting our first, we rolled it out as a step wedge randomized trial in order to add some scientific rigor to this project. And so we're just in the process of analyzing the results now. So we'll certainly, we'll let you know how this intervention has gone. But it's certainly been an interesting process. So secondly is, the second intervention that we've taken is to look at care after acute kidney injury. So there's lots of American and Canadian data to show that nephrologists don't actually see many of these patients after an AKI episode, because first of all, we're not consulted in the hospital. We may not know, particularly if the creatinine comes down to something near normal. We may never have been alerted to this. So if we didn't get consulted in hospital, it's unlikely that we're going to get consulted after hospital discharge. Yet all of the current international clinical guidelines are saying that all of these people should be seen by a nephrologist within 90 days, which of course is ridiculous. So, I mean, if 20% of people in the hospital have AKI, there's no possible way we could be seeing all these people, and we probably don't need to see all of these people. So we know that nephrologist follow-up is rare, but I know the other question is it necessary? We also know, and this is Alberta data, that the use of proven therapies, whether it's ACE inhibitors, statins, is low in patients who have AKI after an AKI episode. So again, if we go back to what the data I showed you before, these people are at high cardiovascular risk. Many of them have CKD after an AKI episode, and they're not even receiving standard CKD care, so whether it's statins and ACE inhibitors. So this is an opportunity to address a care gap. And it does seem that follow-up after AKI does seem to matter. So this is Ziv Harrell, and this is Ron Wald's group from Toronto. And what they found was that patients who had an AKI episode, whose creatinine, who came out, who required dialysis in hospital but came off dialysis, the ones that saw nephrologists had a 24% risk reduction in terms of mortality if they saw a nephrologist and had follow-up care versus those that didn't. And in fact, it did seem to be that nephrologists seemed to provide something unique. So it did matter who you followed up with. If you saw a general internist, you did not have the same outcome as if you saw a nephrologist, which is interesting because you would think that the people who saw nephrologists would actually be the sicker group with significantly more renal dysfunction. But there was something protective about seeing a nephrologist versus other types of cardiologists or other types of internal medicine specialists. And so the question is why? I mean, when I looked at this data, I thought, well, that's kind of bizarre. Like, what is it that nephrologists are doing? And one of the things that I kind of wondered about was maybe we're better at prescribing we're better at cardiovascular risk reduction, and maybe we're more vigilant about monitoring things like hypertension or adverse consequences of medications. So again, this is a paper that one of my former fellows wrote with me a few years back, and it looked at the association of statin use with mortality in patients who had acute kidney injury. And what we found was that in patients there was a significant reduction in one-year mortality in patients who received a statin versus patients who did not. So if you believe that cardiovascular mortality is increased, then maybe these people would benefit from the statin. It kind of makes sense that if you put them on a statin, maybe that might explain some of these results. There was also a dramatic reduction in all-cause rehospitalization, as well as overall cardiovascular events. And again, one could say, well, maybe they're just receiving better care. Maybe this is a marker of clinical care, that patient being on a statin. So we also looked at the use of ACE inhibitors in these patients as well, patients who had acute kidney injury, those who received ACE inhibitors versus those who did not. And this was a really interesting kind we had there were some interesting findings from this analysis as well. So being on an ACE inhibitor was protective after an acute kidney injury episode, but these patients did have a higher risk for rehospitalization for renal causes. They were more likely to have things like hyperkalemia. So perhaps the role of a nephrologist here is that we can start them on these drugs, but we can also monitor them and make sure that they don't run into some of these renal complications. And maybe that's the role of the nephrologist in the care of these patients. So we have used our Alberta data to come up with a predictive score for acute kidney injury. So this particular predictive score was published in JAMA in 2017 using Alberta data. And we were able to sort of just identify 3 or 4 factors in patients who had developed AKI in hospital in terms of who was at highest risk of progressing to CKD within 1 year after hospital discharge. And it's a pretty uncomplicated prediction score. So age, sex, baseline serum creatinine at the time of hospital discharge, and severity of acute kidney injury are the basic parameters that kind of allow you to predict who's going to have that risk of chronic kidney disease after an AKI episode. So the After AKI trial, which is ongoing right now, is a CIHR-funded randomized trial where we're randomizing patients who have AKI in hospital to be either risk stratified using our risk stratification tool, and with high-risk patients being stratified to see a nephrologist, medium-risk patients being stratified to given patient information as well as their primary care doctor is contacted and provided information about management of acute kidney injury, or low risk, in which case the patient is just given information to say that they had an AKI episode and are asked to have their serum creatinines checked within 90 days. So that would be the enhanced discharge planning arm of this trial versus usual care. So usual care might be just being discharged home. As a fail-safe, we've asked all of those patients in usual care to have their serum creatinine drawn at 90 days just to make sure we're not missing anybody. But many of the patients, so we've now enrolled about 140 patients in this trial. This is a pilot study at U of C and at the Foothills Hospital in Calgary and the U of A Hospital in Edmonton. And so we're almost done recruitment for the pilot trial, and hopefully within a year or so we'll be able to give you some results in terms of managing, in terms of the effectiveness of this intervention. I mean, I think the advantage of this is obviously that we can at least identify high-risk patients, and those people are appropriately referred to nephrology versus us having to see everybody who has an AKI episode, because they're clearly people who don't need to be seen. People with no comorbidities, people who who have a normal serum creatinine at the time of discharge. Do they really need to see a nephrologist? Probably not. So in terms of the eligibility criteria for our study, we're really just taking anyone who has a doubling of serum creatinine or more. So we're avoiding the AKI ones. So the 25%, we want them to have at least some significant degree of acute kidney injury. And they have to have a primary care physician. So in terms of take-home messages, I hope I've convinced you that this is within the realm of the work that we do, and that there is work that we can do even though we often don't see these patients. And we can do that from whether it's quality improvement initiatives in terms of identifying acute kidney injury, developing care pathways for early identification and management, or looking at post-AKI care. But I think we have many opportunities where we can probably improve the outcomes of these patients in hospital and after. And with that, I will hopefully, I've convinced you that this is a significant problem and that there is work that can be done in this area. It's not all nihilism. And that there are exciting opportunities afforded by electronic health records and biomarkers. And we may not have specific treatments for AKI, but there's lots we can do to improve the care for these patients. So obviously, just want to say a couple of words to thank all of my collaborators at U of A and U of C, and to say that the trials were funded by CIHR and our strategic clinical network in Alberta. So I'll open it up to any questions for you, and thank you for listening. Questions or thoughts?
I just wanted to, I'll start by just saying, I think that we do have some therapeutic nihilism in nephrology, and we laugh about little bumps in creatinine and say, why would we care about it? And yet, we don't laugh about little bumps in troponin that everybody, and we get excited in the cardiology, oh, it's just a ischemia, but they come and see them, right? And I think that somehow we need to strike a balance, like troponitis and creatinitis might be not dissimilar, and they do portend poor outcomes. And we wouldn't have learned everything we learned so far about AKI if we hadn't had a systematic approach to understanding it. And whilst we don't have treatments now, theoretically, we will over time. And I think that if we don't continue to take care of AKI, then we will lose that as well. And I think that might be something, and I think in Alberta you seem to have a very good systematic approach and continue to own it. Do you want to maybe comment on that?
Yeah, I mean, I would say, I mean, I think the troponin analogy is often used, and I think it's actually, it's not wrong. I think we just don't, just like we didn't really know what troponin and high troponins meant when they first came out, and not every high troponin is an MI. We don't really necessarily know what to do right now with these biomarkers, but what we can say is that they do flag high-risk patients. So whether it's a kidney disease or not, it absolutely 100% does flag a high-risk patient, and those patients probably require some intervention. It may not be what we would typically think would be in our, we would do as nephrologists, but I think cardiovascular risk reduction is a lot of what we do as nephrologists. So I think that, we do have a role to at least play in terms of identifying these high-risk people and figuring out ways that we can effectively manage them. Now, in terms of the strategic clinical networks, I am obviously I have a conflict because I work for a strategic clinical network as a scientific director. But I'll say, so Braden Manns is the head of all strategic clinical networks in the province, and they've been highly effective. They've been a really good way to engage clinicians and patients and clinical operations in the care of, in terms of developing unified care pathways across the province. And that's, I think, where they've been really, they continue to evolve over time. But it's really been a great opportunity for us. And it's a really great way to scale and spread any intervention instead of just leaving it as a local thing in a hospital. And that's true across the board, not just in kidney disease. So we've seen it in endocrinology, whether it's diabetes care, it's now all the same across the province. There used to be a different diabetes, a different BBIT or basal bolus insulin kind of algorithm in every different hospital. And now there's some standardization across the province, and I think that's been hugely valuable.
Victoria or St. Paul's or Columbia, any questions?
Hey, this is Peter Burks, nephrologist with Fraser Health. I'm also interested in AKI and post-AKI care. I'm doing some work with BC Renal. Thanks for your talk. That was excellent. I have a couple questions. The first one was around timing of rechecking creatinine. We're recommending, based on the KDIGO guidelines, 3 months, which in a lot of cases seems a bit long from my perspective. So I just wanted to get your thoughts on that. And I'll ask my second question maybe after you answer.
Well, I mean, I think that's where the role of the risk stratification happens, right? So I think, I think really when you check again depends on the severity of the AKI that you had while that patient was in hospital, what their kidney function is like at the time of discharge. And so, I've been at a number of meetings now where in the States and in Canada, where we've been planning, post-discharge care trials and things like that. We've been talking about timing of interventions, when people should see nephrologists, when they should get their serum creatinines checked. And most people would agree, it probably, for people with severe AKI, it's 3 months is probably long. So, whether that is 2 weeks or a month, it really depends on the status of the patient to some extent. If they're, how well they are, whether they have other comorbidities. Often, as all of you know, many of these people have other specialists that they're seeing. If they have cardiac issues, they're also seeing their cardiologist. And so, timing, I think, is something that we need to figure out, but I think that also is something that's subject to risk stratification. If you're low risk and your creatinine was normal or near normal at the time you were discharged from hospital, 3 months is probably totally reasonable. If you have an elevated creatinine at the time of discharge, it hasn't come back down to anything close to your baseline, then probably checking in days to weeks after you get discharged would be most appropriate. So I think the use of sort of a risk stratification tool is helpful for that.
Sure, thank you. And my other question, I was interested that you guys were using alerts in Alberta, because a lot of the UK literature is kind of alert-based. I guess the question is, how has the response been to those wards using alerts, and is this something you guys are planning on incorporating into the new EMRs being rolled out in Alberta, specifically things like alert fatigue, you know, if weighing the pros and benefits?
Well, it's really interesting. So we did this as kind of a natural experiment. So Calgary had its own electronic health record called Sunrise Clinical Manager, and they've had that for about 7 or 8 years. And and Edmonton was a paper-based until we just got Epic 2 months ago. So we were paper-based until that happened. And so it was kind of a natural experiment. So they were doing e-alerting in Calgary using their electronic health record, and we were actually doing this thing where the SPORE data platform was identifying AKI people, and we were actually having the unit clerks and the nurses log in to identify who had AKI. I think the interesting thing about it is that what we did find is that the awareness of AKI went up dramatically. Like alert fatigue, I think, is a real issue, and I can tell you after 2 months of Epic, I spend a lot of time clicking through all of the alerts and ignoring them. So, I mean, I think in the future, I mean, I was a bit naive to the alert fatigue. I knew it was an issue, and I think some of our future work now is looking into what is the most effective way to alert and manage these patients, because I don't think actually these e-alerts are going to work for us. There is so much alert fatigue. I mean, so for example, in our EMR, even if you're prescribing an ACE inhibitor, you have to go through like 15 warnings and alerts, and have you done a pregnancy test if the person is of childbearing age and a woman, and it's crazy. So, and everyone just basically X's through everything and then goes ahead and orders it. So, you know, one thing that we will have to learn is how to effectively use these. And actually the Epic people did warn us. They said, don't be putting in best practice advisories or alerts for every single thing, because literally every condition the patient has will be associated with some alert, and no one's going to pay any attention to it. So I think that is actually a hot topic for research, is how to effectively use EMRs and to do this alerting in an appropriate way.
Thank you.
Hi, Dr. Pannu, John Penman. I'm a medical biochemist, and fantastic presentation. I'm here to be able to better understand how the lab might have some input into, can you see me? I'm sorry.
Yeah, we can see you. Yep.
The question I have is a very selfish one. Is it possible I could have a copy of your presentation? Just
Sure.
And
it also gets posted on the Renal Agency website, but the presentation itself. But we can, if you email us, we can send it to you.
oh, thank
Sure.
you. I have a friendly nephrologist who will give me a copy, I'm sure. Thank you.
So again, I want to thank you. I think importantly, we learned a lot from looking at the epidemiology of chronic kidney disease and now have new therapies. I think we're going to learn a lot going forward in terms of AKI, not just how to manage it, but ideally we might have new therapies. And I think you've given us lots of food for thought, and if nothing else, I think we'll all take different care. And I think the real thing that I've been wondering about is I don't think we have a systematic province-wide approach to AKI that seems that you've begun to have, that all the nephrologists have bought into the notion that this is something that we care about, and maybe that's something that we can think a little bit about as well. But thank you very much for that.
I'll look it up.